me, right? If I don't record, then you want to listen to later. So please tell me the recording. Try to remember. All right, so again, the smallest volume is tidal volume. The next one is expiratory reserve volume. And pretty much it's as similar as the air remaining called residual volume. If you can take in as much air as you can, called inspiratory reserve volume, it's about 3 liters. And I told you already, it's very important is that what is that volume of air when you say you take in as much air as you can and to blow out as much air as you can. This is known as the vital capacity. It's about 4.7 liters. No matter how much you're trying to take in and blow out, there also is going to be some that is remain. This is known as residual volume. Okay, so vital capacity plus residual volume give rise to total lung capacity, which is this, and it's about 6 liters. Very critical, important in the fact of distinguish between what we consider obstructive lung disease versus restrictive lung disease. In obstructive lung disease, the person have problem blowing out that air. So it doesn't matter which graph you show. In this case, for example, from the maximum versus that volume at 1 second. Okay. So you take that volume at 1 second divided by the maximum vital capacity that person can take in. It should be, normal person, greater than 80%. In other words, right? You blow 80% or more of what you take in if you're healthy, right? But if you are sick, say if you have emphysema, take it out, blow it out is a very laborious process. It'll take you more than 1 second to blow out that 80% of that volume, for example. So that's how you can distinguish between obstructive versus restrictive. Restrictive is, on the other hand, what happened. Oh, it actually shows you here, down here. In obstructive, you can see here how within that 1 second, the amount of air that is blowing out is greater than 80%. Okay. Okay, seems to be some confusion here. The idea here is that in the obstructive lung disease, right? So you're taking the forced expiratory reserve volume at 1 second relative to forced vital capacity. Okay, if it's greater than 80%, you're good. If it's less than 80%, then you have obstructive lung disease. You have obstructive lung disease. Now, on the other hand, this ratio is good, right? But the FVC, okay? So FVC, forced vital capacity, good number to know, I told you, is about 4.7 liters. Right? Now, if the forced vital capacity is low, say it was 3 liters or something like that, right? Then that is restrictive. And it shows you here, restrictive lung disease. So you can see how here, in this case, the maximum air this person can take in here is about, it's really, you can say just the air that you can take in from here to here. That's vital capacity. What is this? It's like, say, 1, and this is 4.5, so that's minus, so that's about 3.5. right? From here to here, it's 3.5. But you look at this guy's right here, is from 1 to 6. That's almost 5 liters. This is normal vital capacity. Normal vital capacity. This vital capacity is low, right? Restrictive lung disease. Now, why is that is? It's because there are material that is occupying the space in the lung. Things like immune cell, things like a lot of the individual take in asbestos, and then there's an inflammatory response to that, and you get a lot of immune cells in this, and so then it just take up the space, so there's no air for it. So that's why the vital capacity is much lower. Okay. So, I think whoever wrote that down, healthy person less than 80%, um, I hope that will clarify to what your thinking is. Again, if FEV, and you will see this again in the question exam next week, the forced expiratory volume within the first second relative to forced vital capacity, if it's greater 80%, you're good, right? You're healthy. If it's less than 8%, then you have obstructive lung disease. Now, someone who has restrictive lung disease like this one, the FEV1 and FVC is greater than 80%. You think that's healthy, but what happened is that the vital capacity is lower. Let's say 4.7 is normal, and they have is 3.6. Okay. All right. Let's move on then. Okay, so here are now we can talk about, there are different kinds of conditions that you can see in the upper respiratory tract. Things like, we can say, the common cold is known as rhinitis that you can see here. Allergic rhinitis is oftentimes a hay fever. Nasal polyps. Now, nasal polyps are usually found in the up in your nose, right? And it's just basically a painless. It's not cancerous growth, right? And, you can look up and you can see a polyp there that is developed, as you will, and it looks like, sometimes it looks like it's dangling. You can see it's dangling. That's a polyp. Okay. Now, sinuses. So in the upper respiratory tract, you have your frontal bones here, right? Maybe the maxillary bones down here, the frontal bones, the ethmoid bone down here. All of that will have sinuses. Okay. And if you have a blockage of the drainage in the sinuses, you can develop sinusitis, if you will. Mucous cells are, they're kind of like, you can think of it as like a swelling sac, right? Kind of like polyps in a way, but polyps are usually found is up in here in the nasal. Well, mucocele, you can have it, in your lip and in your tongue, for example. You have those mucoceles. Sinusitis is basically anything that interfere with that fluid in the sinus, the drainage that can lead that. People get headache and stuff like that. Sinusitis. And I think I want you to know what are the 6 common causes of sinusitis. Sinusitis, can be acute, sudden, and they go away. If it's not, it's going to be around for people who have constant hay fevers or something, can develop chronic sinusitis. Okay, so the 6 common cause of sinusitis are, okay, um, that, you probably see this exam next week. One is pollution, okay. Um, 2 is asthma. 3 is nasal polyp. Certain allergy can cause this, and common cold, cold, a lot of frequent cold, and a deviated septum. Okay. So the nasal septum here is separated, so then that could interfere with the mucosal drainage. So the best way to remember the causes of 6 causes of sinusitis are, um, I, for me, you can write it as an acronym. Like a country, Panama. Well, it's not Panama, but it is Panaca. Okay, Panaca is pollution, asthma, nasal polyp, again, allergy, cold, and a deviated septum. Okay. Pharyngitis is inflammations of the pharynx, and tonsillitis is inflammation of the tonsil, right? Now, um, itis is just means an inflammation and depends on the location. The pharynx is the back of your throat, right? Um, the adenoid, um, the adenoid is the tonsil. Okay? It's one of the pharyngeal tonsil. It's known as what tonsil is. So it's very much similar term, right? Now the pharyngitis, in fact, is very different from sore throat. By the way, okay, so this is different from pharyngitis is different from sore throat. Uh, okay. What does the first word say? Oh, that's different. Different. Um, Pharyngitis. Sorry, let me go back. Um, Actually, it's very similar. So you have a sore throat. That's pharyngitis. Yes. Okay. Pharyngitis is a sore throat. Right? It's the same. It's the same. What I'm thinking about is strep throat. Okay. Now, strep throat is different. So, strep throat is caused by a streptococcus, okay, group A streptococcus. Now, with the strep throat, you can actually treat it with antibiotics, whereas pharyngitis is caused by a virus, and you can't treat it with antibiotics. So let me write it down, okay? So strep throat is caused by streptococcus. And if you want, you can say group A. Okay. Whereas pharyngitis is caused by I'm not spelling this right. Pharyngitis, okay, it's caused by virus. So antibiotic or no good. Okay. Okay. um, Okay, so pharyngitis is the same thing as sore throat, and tonsillitis is pretty much same thing. Okay. The other thing is with the streptococcus is oftentimes is that you see this white sheen on the back of your throat, but on the roof you might see something red, red blotches, if you will. So that's a strep throat. So good two things to note with the sign with the strep throat. Okay, so signs of strep throat are white patches on the tonsil or throat and red spot on the roof of the mouth. Okay. Okay, so laryngitis, the larynx you have is where you have the vocal cord, called the true vocal cords. Um, it's under the vestibular fold, which is a a vocal cord, and the way that depends on the arytenoid and the cricoid muscle contraction that these vocal cord can either abduct, so you get like a very bass sound, or adduct like this, and you get very high note sounds. Um, I'm not going to go into the physiology of that, but the larynx is where your voice box would be, and oftentimes you can get inflammations there in the laryngitis, if you will. And uh, typical person who have laryngitis is that they'll probably have um, a um, a husky or sometimes the little raspy kind of sound. Maybe there's no sounds produced, if you will, if you have inflammation there. That either on the edge of the vocal cord can develop a nodule, a singing nodule, and can often lead to very painful when they speak, but when that cord is trying to vibrate, which creates sounds, so they try not to make so much sound, if you will. Um, and the major causes of laryngitis, I would say that it's viral. Okay, so this is also viral infection. Okay, very similar to a common cold. Um, all right, carcinoma of the larynx. It's the it's very rare in the terms of malignant cell growth on the larynx, but it do exist, and often these people that you often see that would develop carcinoma in the larynx, and we call these what are the two risk factor for laryngeal uh, cancer. Okay, so know these two risk factor. The two risk factor oftentimes you see are smoker. I'm gonna write it down. Smoker and alcoholics. So these are the two. So smoking and alcohol are the two risk factor for developing laryngeal carcinoma. Okay. All right. So the next thing we're going to talk about is the word atelectasis. I don't know if you know the word. The root word for this is tel. Tel means distant, right? Tel means distant, or the end, if you will. So we can say telencephalon, with distant portions of the brain, or you can say, oh, it's a telephone, is a distant void. Television is a distant picture, for example. Okay, ectasis means the process of moving out. Okay, ectasis is movement, if you will, movement. Ectasis, movement. So atelectasis meaning that it's no movement out. So in other words, it's collapsed lung. Okay, so there's several ways that can lead to collapsed lung. Partial, which often that you see, meaning let's say there was a tumor, and so then the tumor is impinge upon the lobe of the brain, so that now the brain, sorry, impinge upon the lobe of the lung, so that the lung cannot fully inflate it, right? So it's partial collapse, or it's full, right? So it's complete, it's full, and this is pretty true. It's like if someone have a pneumothorax, for example, right, which really means collapsed lung. A pneumothorax is meaning that the lung is surrounded by the pleural membrane. So if someone stabbed you in between your rib, so that now air from the outside can go in, the pleural membrane, in fact, help the lungs to inflate because it has a negative pressure. Now, if there is a air that is rushing in from the south, from the outside into the pleural cavity, then it no longer has a negative pressure. So then the lungs cannot, inflate. So we call that pneumothorax. Or you can say transpulmonary pressure, right? So transpulmonary pressure is the difference between transpulmonary pressure is the difference between alveolar pressure, which like the pressure you see in the lung, in the alveolus, and the pleural pressure. Okay. The pleural pressure is the pressure that you see in the pleural membrane. So let's say that here are your lung. If this is a left lobe, you only have two. Okay, so the right lungs have three lobes. The left lung has two lobes. The pleural membrane is surrounding this. That's the pleural membrane. So the pressure here, that's what we mean by the pleural pressure. Whereas in here is alveolar pressure. So the difference between the alveolar pressure and pleural pressure is transpulmonary pressure. This is usually the difference here. So then let's say if this is 786, that's usually millimeters of mercury. This is about 780, it's about 3 or 4, 780, let's say 3 millimeters of mercury, for example. All right. So that there is a negative pressure in this pleural cavity. Now, if air comes in here, so if this right here is also 786 millimeters of mercury. So then the transpulmonary pressure is 0. Okay, so transpulmonary pressure is equal to 0, then that's pneumothorax. Okay, that means collapsed lung, right? So in other words, collapsed lung is only one of the several causes of atelectasis. Okay, atelectasis means it's not fully inflated. That's what atelectasis means. And we're going to see there are 3 causes of that in a little bit. um, that's what atelectasis means. It cannot fully go out. Okay. Collapsed lung is uh, the stabbing, for example, or puncture of the lung, so that now there's no transpulmonary pressure, it can't inflate. That's an atelectasis, all right? Not fully inflated. Atelectasis, there are 3 kinds we're going to say. Some of them is adhesive, some of them is obstructive, and so forth. And it could be acute, you know. Um, and oftentimes the atelectasis here, like in the case of the pneumonia, a pneumothorax acute is often related to stabbing, for example. But it's not uncommon that one of the common causes of atelectasis is post surgery. Okay, so when someone has an operation, for example, and it needs to be intubated, for example, for anesthesia. Okay, so note that post-surgery, a complication that can result from surgery is the inflated lung known as atelectasis. Okay? And there are several causes of atelectasis. You can see here. Okay, there's 3 types: contraction, fibrosis, or adhesive in term. So contracting is something that is holding it, you know, like adhesive things, maybe scarring, so that it prevents it from being fully inflated, right? So that's different mechanism from no transpulmonary pressure. Okay, no transpulmonary pressure is pneumothorax, but this is contraction of atelectasis site. Compression. So if you want to say the if pneumothorax is due, you know, no transpulmonary pressure, most likely it probably is going to be similar to this type uh, of this class known as compression, that external pressure is driving the air out, causing it. Or you can have, you know, like a tumor or elevated diaphragm. Any number of those things can compress uh, on the lung so that it's not fully inflated. Obstruction, this is oftentimes what you see, it's post-surgery, and that is anything that is interfere with the ventilation, air going out. So what happened is that in post-surgery, there's a lot of mucus in the bronchus, and there's an increase in mucus production. Is probably because you know, the anesthesia they use stimulates the bronchial to put out a lot of mucus. And so you get a lot of mucus in the bronchus, and that is interfere with the airflow, or it cannot move, pushes out, and so then air get trapped. And the reason why they call it resorption is because the air that is remain. So let's say, for example, so this is your primary bronchus, secondary bronchus, and so forth. tertiary bronchus. If you get an obstruction here, that means that air will stay in here, right? And air here cannot get ventilated. It cannot go move out. It cannot move out, right? And so air here is, so this is, let's say this is a capillary that goes here, and particularly nitrogen oxides, which often they use in surgery and intubation. So they're not nitrogen now gas is not able to move out. Nitrogen gas can get into the blood, for example. So there's a whole complication. You can see that. This is the idea of, we call Henry's laws, that if the partial pressure is very high, it can now get into the air, can get into the blood, for example. So in this case, nitrogen will accumulate and they get reabsorbed. So hence the name of reabsorption, okay? Or absorption, so reabsorption is same thing. Your job is to distinguish between these three types of atelectasis. Symptoms and often associate with these three types of atelectasis, and because they have blocking the ventilation, CO2 may not get ventilated out, oxygen getting in, so you can see that they get low oxygen content. And always, this is also good to know too, is that because of a particular part of the lung that is collapsed, right? That means there's a space there now. So if it's fully inflated, it will occupy the space. But if it's collapsed, then there's a space, right? So let's say on the left-hand side of the lung, in the cardiac notch, the heart now can move toward that empty space, right? So you can always know whether the atelectasis occurs in the left lung or right lung is because of the displacement of the heart, okay? Displacement of the heart here. And it usually goes to where the area. If it's moved to the left, and more collapsed lungs, move to the right, move to the left because of the left lung is moving to the right, is right lung that is affected. Okay. So here is the the contraction, thoracic changes. This is an irreversible. So you can see here the scarring here, and this has prevented the lung from fully inflate. Okay. I don't know if you guys, as a little, when you're little, you blow up the balloon. If the balloon should have a nice surface, but some of the old balloon, the surface kind of stick together, and they don't inflate very well. That's what contraction atelectasis is. Okay, so here is compression. So in this case is fluid accumulation, like a pleural effusion, for example, we call this. And it occupied normally, this would be air. So it's in here fluid, then this lung cannot be inflated. Okay, so that's something that is compressing on it. So this is compression, atelectasis, lungs. The other thing to note here is that if there are air in this lung. By the way, is this the left lung or is this the right lung? Anybody know? No, you shouldn't say, well, first of all, the answer is right lung. It's because it says his right upper, right? But yeah, you know that the right lung is because of 3 lobes. On the left-hand side, it's only 2 lobes. Now, if it's, yeah, that's right. Now, if it's have air in them, it should have this nice pink color that you see here, right? Now, because of collapse, right, partial collapse up here, then that meaning that it's now, instead of inflated, it's sort of like squeezed in. It has this more darker staining, darker appearance to it, actually. Okay. All right. Okay, so obstruction, here's of course obstruction, so all the air is here is now being absorbed back in the blood. Right? So that's we call that obstructions, and this is pretty common, right? So this is saying this is the most common, that is post-surgery, if you will. So you get a lot of mucus production that cannot be moved, so we're blocking. Um, And one of the common, well, the other thing that is often associated with this obstruction, although they don't know the mechanism yet, is known as the right middle lobe syndrome that you can see here. Okay, and right middle lobe syndrome, typically an X-ray that you can see here is that now if it's air, it's, you know, X-ray can go through it, and you can see is that um, black, but if it's, you know, some like solid right here blocking the X-ray on the film, you would see it's more like a white appearance. This is a right middle lobe syndrome. Okay, absorption atelectasis. Again, make sure that you know this is the one that is most associated with post-surgery, and that's because they produce a lot of mucus, and the mucus that is interfered this. Actually, this is also known as bronchoectasis, and bronchoectasis is one of the four or three causes of restrictive obstructive lung disease. Okay, bronchoectasis, you can see here. All right. The other one being chronic bronchitis, emphysema, and asthma. Okay, so I think I told you that already, right? The four causes of obstructive lung disease. Okay, so most of you already know when we're talking about edema, you know, pulmonary edema, meaning that too much excess. We already know that one of the common causes of pulmonary edema is left-hand side heart failure. Okay? So that means the heart is not able, the left-hand side not pumps out the blood. So it's receiving blood, but it's not pumping out. So it cannot receive anymore on the left-hand side. So there's a backflow, right? It's going to the lung. So that's self-explanatory. Okay, that we call that is hemodynamic, which basically causes pulmonary edema. The other cause now that we can talk about is known as microvascular injury, and microvascular injury has steps that are involved. Okay, so you need to know these four steps, and it's very similar to how the pathogenicity of coronavirus in the case of some people who have a pneumonia, for example. And the first cause of, you know, of these, we're talking about the second causes of pulmonary edema caused by this microvascular injury is that the first event that you see is the dead, you know, your alveolar cell death. That's the first thing, okay? Alveolar cells death. So in the case of the coronavirus, you know, the virus themselves that's replicated in the alveolar, and they come out and they damage the alveolar cell, right? But so that's related to COVID-19. But for most people, right? So a good exam question might be is, you know, a firefighter might go into a room and rescue a child from a burning building, for example, right? So what kind of, you know, what you expect to see in the lung in this child, and you can predict is that the child in a, you know, in a burning house or building, it's inhaling the gas, if you will. So if you inhaling these, even, you know, toxic fume or hot gas or something like that, that can comes in and it damages your alveolar cell. That's the first thing, you damage it. Okay. The second thing is that as the cell is dying, it's dead, there's going to be an inflammatory response. Okay, that's the second thing, an inflammatory response you can see. And that inflammatory response, as a result of that inflammatory response, you're going to get a lot of protein or exudate, if you will. And the oxidate now is lining the lumen of the lungs, if you will, right? And that because there's a lot of proteins there, and this thing, that used to be should be air, now it's become a gel-like, and it does is interfere with the oxygen loading into the blood, and the CO2 unloading. Uh, as such, that exacerbates the situation, if you will. So in the case of microvascular injury, oftentimes will resulted in what we consider as acute respiratory distress syndrome, and that's what often that you see in adult. Okay, in children, they might develop acute respiratory distress syndrome, but that's often associated with let me write it down. Associate with the lack of surfactant. Okay. Surfactant, as you know, it's kind of like a soap in a way, and that is one end of the molecule is hydrophilic. This might be hydrophilic. And this end is, more like hydrophobic. Hydrophobic. So one end is love the water, and the other end hate water. And because of this property, if the alveolars collapse, and to prevent water surface tension, that means water can interact with each other to prevent it from being fully inflated. So you have the inner lining, like the alveolus right here. Let's say this is alveolus. If it's coated with surfactant, then it actually can inflate. But if it's no surfactant, once it's collapsed, then it cannot open up again. Okay, so that's in children. We call it respiratory distress syndrome. Oftentimes, children who are born by C6, cesarean section, for example, do not have a lot of surfactant produced. Turns out that as the child goes through the birth canal, they start to produce a lot of surfactant, which then, help the child to inflate the lung. And then, of course, some childs have a gene defect so that they can't produce surfactant, and such, they would have this collapsed lung. And these two are called respiratory distress syndrome. Okay. Any questions so far? Are there 2 or 4 steps in microvascular? There are 2 ways that you can lead to pulmonary edema. Okay, pulmonary edema are either left side heart failure or microvascular injury. And even though here, for example, I say acute respiratory distress syndrome, and in this case, acute respiratory distress syndrome in adult is very similar. It's exactly the same thing what we see in microvascular injury. The steps are right here. Number 1, okay, alveolar injury or death. Okay, so alveolar, you see that. So usually smoking inhalation is good. But it's a number of things, toxins and stuff like that. IV drug user that develops that. COVID-19. So the first thing you see is the damage of the alveolar cells. Okay. The second thing that you see is inflammation that follows it. All right. That's exactly what you see with COVID-19. The third thing that you see is that resulting from the inflammation, you're going to get a lot of protein, okay? Exudate, you can see that, a lot of protein. And this will form sort of like a gel-like membrane, if you will. And that's further interfere with the gas transfer, right? And this gel-like is usually part of that, okay? And then the fourth thing then you can see here that exacerbates this, so now difficult we call it external respiration, right? So by external respiration is oxygen loading and CO2 unloading. Okay. But and this is exactly what happened is in COVID-19 is that they got infections with the virus, coronavirus. It's damaged the alveolar cells. Inflammatory response occur, right? There's a lot of proteins, rich. There's going to be, and that protein rich is basically formed this gel-like structure, and then it exacerbates the situation. Now they cannot breathe. They cannot involve in oxygenating the blood. And so then you have to put the person on a ventilator, which is actually help them oxygenate their blood. What is the question with unloading? Do you guys not know that external respiration, meaning oxygen loading and CO2 unloading? So people go to ventilator because oxygen cannot load it. No, oxygen loaded into the blood, okay? Oxygen loaded into the blood, not out. And CO2, okay, unloading out of the blood. Okay, so actually you guys should know the difference between external versus internal respiration. Okay, in the internal respiration is let me put this way. In the external respiration, I thought you guys know these terms. Is the gases exchange between the lungs and blood. Okay? In the external respiration, gases exchange. Okay, good. In the internal respiration is gases exchange between the blood and the tissue. Right. Thus, in the internal respiration, right, you would say oxygen is unloading, so unloading out of the blood, and CO2 is loading, right? So the blood is collecting CO2. The blood is, dumping oxygen in the tissue, and the blood is taking up CO2, so coming back to the heart as part of the venous circulation, right? Or you can call that deoxygenated blood, as a the deoxygenated blood. Mhm. There you go. So then it goes in the lung. The lung is now it dumps CO2, but it takes up oxygen. So we call that loading oxygen, unloading CO2. Right. And now if it's loading with oxygen, it's now defining as oxygenated blood. Okay, so why don't we stop here for the recording, take a 5-minute break,